So now for something completely different, very non-technological talk, and I was given the talk of improving peri-operative outcomes, and I thought, oh dear me, not again. And you probably thought, not again as well. He's going to bang on about enhanced recovery. So before there's a mass exodus for the doors, I'm not going to talk about that. I'm going to talk about one very important element, which is prehabilitation.
We came to hear about the hasn't done there.
Okay, you can all leave.
Sorry.
Oops, what have I done here? Why is this not working?
It's just one slide, isn't it?
That's it.
Any questions?
What am I doing?
Hit the buttons or don't hit them.
Don't hit the buttons.
Because you just knock it off. It makes it go in the back.
Which button shall I press then?
That
Oh,
one.
that one. Ah,
See,
that
see the
one.
tape? Don't touch the tape.
Don't touch the tape. Okay. Don't touch the tape. Fine. Those of you at BTOG a few weeks ago will have seen the launch of the new NLCA data looking at lung cancer treatment in this country. And we can see that we are getting better. 18% of women are having an operation and 15% of men are having an operation. But if we look at the 1 year overall survival for lung cancer, it's dreadful, isn't it? Look at that. It's 38% of people will be alive at 1 year after their diagnosis. And that's better than it was. It's better than 5 years ago when it was 31%, but it's still pretty poor. And this is the challenge. And this is the challenge of treating lung cancer. We have this huge cohort of people who just aren't fit for surgery. And we're operating on around 15% of them. And they're the ones, early stage, good performance status. And so is there any way that we can make that blue box bigger? Can we get more people from the red box, the inoperable box, into that blue box? And maybe there is. Now, it depends on who you ask what the solution is. And so if you ask all the surgeons in the room here, then they're going to stand up, blow up their chests and go, yes, I'm going to operate on more N2 disease. Okay, fair enough, go for it. Or I'm going to do some real bad boy surgery. I'm going to start doing carinal resections and all these other fancy things that you heard this morning. Or possibly, which is maybe more realistic, VAT segmentectomy, yes, then maybe we should be doing more of those. Or do you accept impaired lung function? I'm not sure that we should. So, okay, let's ask a different group of people. Let's ask the physicians. And the physicians will say, well, the surgeons just aren't doing enough. Let's hammer them. We'll do an audit, and then we'll do another audit, and then we'll do some screening as well. And we'll show that they're not doing enough work, and we'll get them to increase their resection rates that way. Okay, so maybe there's another answer, because this is the ideal patient, isn't it? When you walk into your clinic room tomorrow morning, this is who you want to see sitting there in front of you. Maybe for many reasons, it's who you want to see. But if you're going to operate on someone, then Jessica's the girl that you want to operate on, isn't it? Because you know that she's going to withstand. I have to be careful for my turn of phrase here. Yeah. She's going to withstand any operation that you want to do on her. But the reality is that that's the patient that's been referred for the lobectomy for lung cancer. So maybe there's a more rounded solution to trying to improve the number of people having surgery, and maybe that is prehabilitation, not just improving the number of people having surgery, but also those having non-surgical treatment as well. So what is prehabilitation? Now, it's a horrible word, but it means preoperative rehabilitation, or it's the process of enhancing the functional capacity of the individual to enable him or her to withstand a stressful event. And it's relatively new, or it's certainly new in the context of thoracic surgery, but if we look at this paper from Montreal, this is Franco Carlia's group, where they've really pioneered prehabilitation in colorectal cancer surgery. He's taken two groups of patients. The first group has prehab for 4 weeks and then rehab for 8 weeks after their surgery, and then the other group has rehab for just 8 weeks. And it's a home-based intervention, so some moderate aerobic and resistance exercises, some nutritional supplementation, and then some sort of Zen-like relaxation exercises as well. And it makes a difference. So we can see the solid line is the prehab group, and in the first two dots are when they're first diagnosed and then when they come to surgery. So the prehab group get fitter, they get fitter. Whereas the people who are not having prehab, they're clearly just sitting at home watching daytime TV, and they get less fit as they're waiting for their operation. Then, of course, there's the impact of the surgery. You get less fit because of the operation that you've had. And then look what happens afterwards. They go through rehab, and those patients who have had prehab beforehand, so in other words, they're fitter before they come to surgery, are fitter when they're fully recovered from their operation. So prehab, we can really think of prehab as having four components. There's smoking cessation, there's nutrition, there's patient education, there's pulmonary rehabilitation. I'm going to talk about three of these. I'm not going to talk about patient education, so if anyone's wanting to hear about that, you can leave. But the evidence on that is slightly sketchy. But when you look at those four elements and then look at the new gold guidelines for COPD intervention, you can see that there's huge similarities in the treatment of COPD and prehabilitation. So there's an emphasis on smoking cessation, an emphasis on pulmonary rehabilitation, and an emphasis on nutritional supplementation. So smoking cessation then. If we're looking at how we're going to treat someone with COPD, then you can spend billions of pounds, and the healthcare industry globally does spend billions of pounds using tiotropium and other inhalers and fancy drugs. When actually what we should be doing is vaccinating people and then getting them to stop smoking, because that's the most cost-effective way to treat your emphysema, and pulmonary rehabilitation as well. So let's have a look at stopping smoking then. This is a paper that came out in Chest at the beginning of the century, and it looked at the relationship between the preoperative smoke-free period and the number of pulmonary complications that you got after a lung operation. And the base to which everything was compared was the never smoker. So if you're a current smoker, then you are more likely to have a pulmonary complication. That's not surprising. But interestingly and somewhat paradoxically, if you've just stopped smoking 2 to 4 weeks, then it seems that you've got a higher risk again of having a pulmonary complication. But then you can quit smoking for more than 4 weeks and then have your surgery, then those risks seem to go down. So they concluded from that preoperative smoking abstinence of at least 4 weeks is necessary for patients to undergo pulmonary surgery. So that's one way of looking at things. But the way a lot of people interpreted it was, well, don't bother stopping smoking. We're just going to operate on you anyway, because it's better if you carry on smoking. And I know there's at least one surgeon in this room who signs up to that. Yes, Eric. Yeah. So then this next paper came out in Chest a few years later, again looking at the timing of cessation of smoking and the impact of pulmonary complications. And they divided patients up into 4 groups: the never smokers, those who had stopped smoking but more than 2 months ago, the recent ex-smokers, and then the current smokers. And they found that never smokers, the incidence of pulmonary complications pretty low at 8%. And then it didn't matter whether you were a smoker and a recent ex-smoker. The incidence of complications was exactly the same. So they didn't see this paradoxical increase in pulmonary complications. And then this big mining of the society database, looking at the impact of smoking cessation before lung resection, showed a very similar thing. Essentially, your risk of hospital death and pulmonary complications after lung cancer resection is increased by smoking, and it's mitigated slowly by your preoperative cessation. There doesn't appear to be an optimal time interval to stop smoking, but they should be cancelled about stopping smoking irrespective of the surgical timing. But just to confuse things even more, this is in this month's European Journal. So refraining from smoking shortly before lobectomy has no influence on the risk of pulmonary complications. Okay, so they have got smokers and recent and ex-smokers. That's people who have stopped smoking, I think, within the last 3 months. And they had very low incidence of pulmonary complications, 4.5 and 3.7%. You go, well, this is weird, because this is lower than anything that's ever been reported. And then you look at where it's come from. This is from Salamanca in Spain, and if any of you have been to Salamanca in Spain and see what they do there, then it's like a military camp. The patients are just flogged before their surgery and flogged after their surgery. They're not allowed to sit still for a minute. So I think the message of smoking cessation is lost in the whole package that they're providing there. So a little bit about nutrition. Two big studies from France and from the States looking at influence of nutritional status and weight on outcomes. And for anyone who's a little overweight in the audience, you don't need to worry because that doesn't affect your outcome for surgery. But if you're skinny, if your BMI is less than 18.5, then that is bad news. So you do not do well after your lung operation. So we use certain things. So we use build-up drinks, the 40 sips or the 40 juice, and then we use complex carbohydrate drinks beforehand as well. But really, is there enough time to influence influence someone's BMI before surgery? Probably not, although we should supplement them if they are very thin. So what about pulmonary rehabilitation then? Well, if you look at the activity of people with lung cancer, you'll find that physical inactivity is really very common. In fact, only a third of patients with lung cancer meet the chief medical officer's recommended activity levels. And the activity levels in lung cancer patients are lower than healthy age-matched peers. And we know that inactivity in itself is a risk factor for cancer as well. But why? So patients are inactive for a large proportion of their life. So we said before, it is a risk factor for cancer. But then, of course, the cancer itself can make them inactive as well with their fatigue and weight loss as a result of the disease. So that asks, the obvious question from that is, can health outcomes be improved by intervening to improve physical fitness? If we look at all the fitness guidelines for surgery, so this is the BTS guidelines, and you'll see that a functional assessment is at the heart of that. And if you look at the European guidelines, then exercise testing is at the heart of that. And the same is true of the American guidelines, as exercise testing at the heart of all this. So the guidelines recognise that there's no correlation between FEV1 and transfer factor, so that's good, that's better than the previous guidelines. There is an emphasis on the use of functional assessment, fine. There's too much focus on mortality, arguably, except the BTS guidelines. But there's very little emphasis on fitness being a modifiable risk factor. In fact, the patient's fitness determines the treatment, and have we got that the wrong way round? Should we say to the patient, this is your ideal treatment, now let's get you fit for that? So this group from Italy tried to address this a little while ago. This is nearly 10 years old now. Preoperative pulmonary rehabilitation in this group of high-risk patients, VO2 max less than 15, and they had 4 weeks of pulmonary rehab, and they managed to improve the VO2 max by 2.8. Over that 4-week period, which is it's okay, but it's a fairly modest improvement. However, there was a long length of stay and significant post-op morbidity in these patients, so they weren't really able to show a great benefit from pulmonary rehabilitation. But this is a nice study. There's another Italian study looking at pulmonary rehabilitation in early-stage lung cancer patients, and they enrolled them on a 4-week preoperative pulmonary rehabilitation program. And look at this, 50 minutes of respiratory physiotherapy and 40 minutes of aerobic workout 6 days a week for 4 weeks. Bloody hell, I couldn't do that. But maybe I should, because if you look at how, at the fitness levels afterwards, so before rehab, their VO2 max was 12.9. After 4 weeks, they got it up to 19.2. That is absolutely remarkable. So you've gone from someone who's borderline for a lobectomy to someone you probably happy to do a pneumonectomy on. So that's absolutely incredible what they've done to these patients. And then Rocco's group in Napoli, similar sorts of study. This time it was a randomized controlled trial, and they had 40 high-risk patients with COPD, all with a VO2 max of around 15 or so. Again, a group that had pre-op pulmonary rehab increased their VO2 max, and then after the lobectomy, it was back down to their pre-op levels, whereas those who didn't have any rehabilitation, rehabilitation got less fit and then were less fit again after their surgery. And of course, in this country, the Birmingham group and their ROC program have had a much more pragmatic approach, where they've just taken all comers, not just your people who are unfit for surgery. It's all comers. It's like, right, this is our outpatient-based interventions of pulmonary rehab and smoking cessation and education and nutritional assessments. And they showed that there was an improvement in pre-op FEV1 and 6-minute walk and a trend towards reduced pulmonary complications. And you wonder if you just focused on the high-risk patients, I think you would have shown significant results there as well. So let's look beyond that, though, and VO2 max and long-term survival, because this is an interesting paper from Cancer that showed that VO2 max is a strong independent predictor of long-term survival in lung cancer by itself. So independent of cancer stage, VO2 max will determine your longevity. And Brune showed the same thing as well. VO2 max of greater than 60% is associated with an improved 5-year survival. And looking beyond VO2 max, this new, well, it's not new because the physiologists are using it a lot, but something that we're beginning to understand more about, the ventilatory efficiency slope. The higher it is, then the worse your fitness. And so this group took high-risk patients, so FEV1 or DLCO less than 40%, with a VO2 max greater than 10, and they showed that if your ventilatory efficiency slope was greater than 35, your 1-year survival was only 40%. Whereas if it was less than that, it was an 80% 1-year survival. So remarkable how your fitness can have an impact on your 1-year survival. So to conclude then, why should we be thinking about prehabilitation in lung cancer patients? Well, I think because we've got two groups of patients. We've got those who are already fit for surgery, but we want to improve their outcomes. And then we've got those who are unfit for surgery, and you want to make them fit for surgery. But maybe more importantly, so we do improve their fitness, but we engage the patient, which I think is really important. We might improve their resection rates. We may improve compliance with other cancer treatments, and we may improve long-term survival. We go back to our box. I think all of the things are important, but prehabilitation is possibly the most important of all these factors. What's going on in the world at the moment? In Denmark, we've got the ProLuca study, a feasibility study. It's not feasible. So they've given up because the healthcare system in Denmark is so good that you've only got 1 to 2 weeks between diagnosis and surgery, so you just can't, they can't fit the program in. The Mayo's running an RCT of 200 patients, so we'll see with Shanda Blackman. So we'll see what comes of that. And in this country, Glasgow, doing a prehabilitation study with patients undergoing coronary artery bypass surgery or lobectomy. And so that's going to be interesting to see what happens when that reports. In the future, we need to define the prehabilitation components. Smoking cessation, nutritional intervention, but particularly exercise. When, what, how long? What are we trying to do with these patients? What are the short and long-term effects? And then finally, in this technological session, my final line is on technology. So wearables, Fitbits, and all the rest of it, and then apps. And maybe Babu can tell us a little bit about the great app that is coming out of Heartlands. Finally, a little bit on ERAS. The ERAS guidelines are going to be launched at the ESTS at the end of May. Thank you very much. Thank you.